So welcome to this lecture, ladies and gentlemen. Uh, we want to continue with lymphomas. Yeah? We have been remember we were talking about proliferative disorders of white blood cells, and we looked at leukemias. Uh, First of all, we looked at reactive proliferation. Then we looked at leukemias. And after looking at leukemias, now we want to look at lymphomas. I hope you still remember how lymphomas basically form. Lymphomas can be defined as, cohesive tumors of, of the immune system. Yeah, so that is basically how we define lymphomas. So in this presentation, we are going to be going through, lymphomas, and what the different types of lymphomas are, and of course we shall also look at other tumors which are not necessarily lymphomas in this presentation. In this presentation, we shall also look at Wilm's tumor. Yeah, Wilm's tumor, not necessarily lymphoma, but it is a nephroblastoma. Yeah. So, but just to kick off this, it is very important for you to know about the lymphatic system. Yeah, and of course the functions of the lymphatic system we all know very well that they are responsible for fluid balance. There's an aspect of lipid metabolism and also defense. Yeah, those are the three things that are very important as far as the lymphatic system is concerned. And we are going to see that most of these tumors actually develop within the, within the lymphatic system. Yeah, like for example in the lymph nodes. Yeah, so it is very important for us to know that. And of course, the anatomy of the lymphatic system, and more so the organs or the structures that follow or make up the lymphatic system. These are structures like the tonsils, the lymph nodes, the spleen, and and the thymus in the young ones. Yeah, the thymus in the young ones. So these structures are very important for you to know because lymphomas can build or can come out of these. Yeah. So basically, you needed to know what lymphatic organs are, what the function of lymphatic system is, and the general organization or the general anatomy of the lymphatic system. Before we move on to lymphomas, yeah. Now, there can be alterations in lymphoid function, and this is where you have issues like lymphadenopathy, and so lymphadenopathy might be as simple as a result of infection. Yeah, but we can also have lymphadenopathy as a result of tumors. Yeah, so these are some of the alterations. In other words, the change from the normal of the normal lymphoid function. So we end up having adenopathy, rather lymphadenopathy, and in here we basically mean things like enlargement, yeah, enlargement of these lymphatic structures. So and these can be as a result of neoplastic disease, as you can see in the presentation, inflammatory conditions, endocrine disorders, or even lipid storage diseases. Yeah, but today we are going to mainly concentrate on neoplastic conditions that basically bring about the lymphomas. Yeah. So when we talk about lymphomas, they are of two types. Yeah. They can be actually of three, but we are going to concentrate on two. They can be Hodgkin's, what we talked about yesterday, Hodgkin's lymphoma or non-Hodgkin's. And if you remember very well, with Hodgkin's lymphoma, we said they are characterized by cells, and these are the cells. These cells are called Reed-Sternberg cells, and they are basically giant cells with two nuclei. having eyes like an owl. Yeah, so those are the characteristic features of Hodgkin's lymphoma. And then non-Hodgkin's, we saw that they come or they develop from internal structures, and they are less predictable, and they are, they do not respond well to chemotherapy. Yeah. We also have what we call multiple myelomas. We're not going to talk about these, but they are also present. Yeah, myelomas. As a result, they are also, lymphomas. Yeah. So basically, the incidence of non-Hodgkin's has basically increased as a result of immune deficiency, especially with age. Yeah, and also as we said earlier on, the reason as to why these lymphomas come about is as a result of excessive uncontrolled division of the cells, the hematopoietic cells, and as a result, basically the excessive growth, and then they accumulate in the lymph nodes and other sites. Yeah. And they end up producing tumors. Yeah. And we shall note that lymphomas usually start from the lymph nodes of stomach, or even small intestines, and that is usually typically for non-Hodgkin's kind of like lymphomas. Yeah. All right, so let's talk about Hodgkin's lymphomas. These are approximately 26% for 100,000 men, and about 19 per 100,000 women. So in other words, they are more prevalent among men compared to women, and the mean age of diagnosis is usually 64, and usually the incidence rates have decreased in the older due to what we refer to as the good diagnostic measures, or the improved diagnostic measures, whereby they pick these lymphomas earlier before they become trouble. Yeah. So basically, the improvement in diagnostic measures has basically helped in decreasing the incidence of these conditions. And we note that Hodgkin's lymphoma usually peaks early in life. Yeah, it peaks early in life in the second and and the third decade. So people in their 20s and 30s, that is where we usually that is when the lymphoma actually peaks. However, it might not be diagnosed. Yeah, it might not be diagnosed at that stage, but it might be building within, but might not be picked up in the second and third decade of life. Yeah. However, they can be picked up, and most of them are picked up, as we saw earlier on, in the sixth and seventh decades of life, and basically that is what we refer to as the median age of diagnosis. So most of them are picked up, in the sixth up to seventh decade of life. Now, that is an example of a picture with a classic, Hodgkin's lymphoma. Yeah, and this gentleman was lucky. As you can see, it's basically an extreme case. Was lucky that it was actually it came up and was picked up as early as he was, 23, and then was started on chemotherapy. Yeah, And as he was started on chemotherapy, as this one basically regressed, another one started in the in the armpit. Yeah. So basically, Hodgkin's lymphomas usually like lymph nodes where they can easily be visualized. What we talked or mentioned about earlier yesterday. Yeah. They are usually in lymph nodes that can easily be visualized, like here, like here, where you can easily see them. And on the other hand, the non-Hodgkins might develop in the lymph nodes of the GI, those or extranodal tissue where those where they cannot easily be seen. Yeah, you might not necessarily see them. Yeah. So basically, that is a typical example of an extreme case of Hodgkin's, Hodgkin's lymphoma. Now, usually, what actually happens, as we saw earlier on, what actually happens is there is, as we mentioned, as we mentioned earlier, these cells lose their ability to divide, yeah, and so they start dividing uncontrollably. They start dividing uncontrollably, and they end up forming masses or cohesive masses within the tissues, within the lymph nodes, the extranodal tissues, and sometimes even within the bone marrow. Yeah. So basically, what happens is as far as the pathophysiology is concerned, uncontrollable division as a result of. Remember, we talked about what predisposes people to leukemias. Almost the same as the etiology or as the risk factors for lymphomas. Yeah. So, however, in this particular Hodgkin's lymphoma, you can see in the slide the characteristic Reed-Steinberg cells. Yeah. Reed-Steinberg cells are basically a giant cells with two nuclei, looking like like an owl, yeah, owl's eye. So that is those are Reed-Steinberg cells, yeah. So lymphocytes predominant, basically lymphocytes are the predominant cells, and usually present with early stage disease. And longer survival and fewer treatment failures. So usually with Hodgkin's lymphoma, the prognosis is quite good. Yeah, the prognosis is quite good when rather they really respond well to treatment. Yeah, they really respond well to treatment. And for that case, someone can have a longer, survival, years of survival and all that. Yeah. And so basically that is in simple terms, that is Hodgkin's lymphoma. Now, how does it basically manifest? You can see discovery of symptomatic mediastinal masses on routine chest X-ray. Sometimes it might not be visible, yeah. But when especially in the outside world where they do routine investigations like routine chest X-ray, then they can pick up some of these masses. So they can discover an asymptomatic, mediastinal mass, which is usually picked up on X-ray. Then we have intermittent fevers without other symptoms. You can have lymphadenopathy in the HIDA and mediastinal nodes. And then you can also have retropenial nodes, can involve vertebral bodies. Spinal cord involvement is usually common, especially with the lumbar and cervical region. Then you have skin manifestations. These might include psoriasis, eczematic lesions, and sometimes itching and scratching. Yeah, and then pericardial involvement. Yeah, involving the heart as which might lead to pericardial friction, pericardial effusion if some of these basically metastasize into the into the structures of the heart. So those are some of the clinical manifestations of this Hodgkin's lymphoma. We are saying it can be an asymptomatic mediastinomas. You can have fevers, intermittent fevers. You can have hilar and mediastinal, lymphadenopathies. You can have retrosternal nodes, involving the vertebral bodies. You can also have the spinal cord being involved. You can have skin manifestations, and then heart issues, or when you have pericardial involvement. So those are some of the manifestations for Hodgkin's lymphoma. Now, so it is very important, as far as evaluation and treatment is concerned, careful evaluation, including, chest X-ray, as we said, things like lymphangiography, and then biopsy, because for us to determine whether it is Hodgkin's or non-Hodgkin's, then we need to do a biopsy. And of course, this is done by the oncologist who will determine the presence or absence of, Reed-Steinberg cells, and therefore conclude if the Reed-Steinberg cells are present, then they'll conclude that indeed this is Hodgkin's lymphoma. So effectiveness of treatment is related to age of the individual and the extent of the disease. You remember we talked about, just to take you a little bit about the acute and chronic leukemias, yeah? And also, if you still remember very well, we said that treatment, especially in leukemias, one of the major players is the severity of the disease, or the extent, and the age, yeah? So even in this context, as far as lymphomas are concerned, the age, yeah, the age of the patient, and even the extent of the disease, how far the disease has gone, basically all these determine the modality and the effectiveness of treatment. Now, there are now new, which unfortunately we do not have in Uganda at the moment, monoclonal antibodies, yeah, basically are being developed to basically try to these are developed, and they help in kind of like destroying the lymphoma, destroying the cells. And of course, this is a new technology which is not in Uganda at the moment, but in Uganda we have use of anti-cancer drugs. And these ones are quite effective, especially when it comes with Hodgkin's lymphomas. I hope you have done anti-cancer drugs. Though for you to really get a glimpse of these, then maybe you need a rotation into heart, the Uganda Cancer Institute. Yeah. So, but what the point to take home here is that these drugs, rather these lymphomas, are basically treated with anti-cancer medication, of which you have covered already. All right. Now let's talk about non-Hodgkin's lymphoma. These basically cancers are differentiated, from Hodgkin's lymphoma by absence of Reed-Steinberg cells, and the median age of diagnosis is usually 67. And you remember what we said about these lymphomas? They basically come, or they arise from the extranodal tissues, yeah, like the spleen, like the spleen. Yes, it's like the spleen. So those are some of the extranodal, the tonsils, yeah, extranodal tissues. So they can come from there, and it's And usually, as we mentioned yesterday, they are unpredictable and quite resistant to anti-cancer therapy. Yeah, they are unpredictable, quite resistant to anti-cancer therapy, and for that matter, they are more aggressive. Yeah, they are more aggressive, and it is thought that newer treatment modalities are basically improving survival rate. Otherwise, these are, more aggressive than the non-Hodgkin's lymphomas. Yeah. So lymphomas most likely originate, of course, as a mutation, just like non-Hodgkin's. Yeah. And these mutations come up as a result of what we saw earlier. The different risk factors. Yeah. So most common is alteration in the translocation in the normal chromosomes, which is called the NHL. Yeah. So basically, the point to take home here is that there is a mutation, and this happens as a result of either a translocation or a transfer of one gene from one site to another, bringing about an abnormal, chromosome. Yeah. So basically, these they all come as a result of mutation. And risk factors are basically family history, exposure to these mutant chemicals, or what we refer to as the mutagenic chemicals, radiation, infection with certain cancer-related viruses, and all those things. Yeah. So basically, almost the same as Hodgkin's. Yeah. So non-Hodgkin's is basically a disease of middle age, usually found in individuals more than 50 years old, and they are categorized by level of differentiation, cell origin, and rate of cellular proliferation. Yeah, and the tumors with the characteristic nodular pattern vaguely resembling lymphoid follicular structures are less aggressive and than those with a diffuse pattern of proliferation. In other words, they are saying that depending on the behavior of these cells, or depending on the behavior of these cells, if they diffuse the structures, the lymphoid structures, then they are more aggressive. But if they don't, yeah, then they are less. If they form follicular structures, if they clamp with each other and form follicular structures, then they are not as aggressive as the ones that diffuse, through to have a diffuse pattern of proliferation. And with diffuse, we mean, if you still remember what we said with leukemia, it's like flowing, yeah? Flowing, that is basically what we mean by diffuse. So small cell lymphocyte lymphomas are less aggressive than large ones, which are intermediate to high grade in aggressiveness. And of course, this is explained as we explained in leukemias, that as you move towards the mature cells, they become smaller, they become more differentiated, and they become less dividing as you move towards the mature cells. So in this particular context, the small lymphocytic lymphomas are less aggressive because, one, they are less dividing, they are more differentiated than the blastic, and then they are less, they are even smaller. Yeah. So they become less aggressive, yeah, than the large ones which belong to the blast. Remember, we said in the blast stage, what actually happens is that we have a lot of division. We have a lot of division. We have a lot of division in the blastic phase. And so if we have a lot of division in the plastic phase, then those cells are more aggressive, or the condition will be more aggressive. As far as the clinical manifestations are concerned, you have things like cervical, axillary, inguinal chains are the most affected sites. Yeah, and the swelling is painless. The nodes have have enlarged and transformed over a period of time, over a period of months and even years. Other sites of involvement, maybe the other thing I should mention here is that not all the superficial or peripheral lymphomas that you see are basically Hodgkin's. No, some are non-Hodgkin's. We said the hallmark of this is biopsy. The hallmark of this is biopsy, where they see either the presence or absence of Wilstenberg cells. But we are saying that despite that, yeah, non-Hodgkin's lymphomas usually, in most cases, in most cases or in most patients, you will find them in the extranodal tissues and places that are usually not accessible, which is opposite with Hodgkin's lymphomas. Yeah, but even non-Hodgkin's can be found in places that are accessible. So I don't want you to be confused along in that area. So that is why we can find them in the cervical, in the axilla, and even in the femoral chain. Yeah, because they not only affect the extranodal tissues and places that are not accessible, but also can sometimes be visually seen. And we say the hallmark is basically biopsy to determine presence or absence of Wilstenberg cells. So other sites of involvement, we have the GI, the bones, the thyroids, and the testes. Internal structures where they cannot easily be seen. Some individuals have what we call retroperitoneal and even abdominal masses with symptoms of abdominal fullness, things like back pain, ascites, leg swelling, among others. And sometimes individuals with low-grade lymphomas present with a painless, peripheral adenopathy. Yes, so basically, these are some of the clinical manifestations. So there is a visible, or there should be a swelling. Remember, lymphomas are cohesive masses. Yeah, so there should be a swelling. There should be some kind of swelling. All right, so more so to clinical manifestations, night sweats with elevated temperature of more than 38. We have weight loss as well as extracellular involvement. These are basically common in the advanced stages. Yeah, and then you also have cytopenia, reflective of bone marrow involvement, is basically observed. Issues like hepatomegaly, splenomegaly are also common, basically in the extranodal tissues. Fatigue and weakness are also prevalent in advanced stages. Yeah? And immediate and high-grade lymphomas present adenopathy with more than 1/3 of individuals having extracellular involvement. So in other words, we are saying that with non-Hodgkin's lymphoma, we have what we call extranodular involvement, which does not happen so much as far as Hodgkin's lymphomas are concerned. So the common sites are basically the GI, the bone marrow, the genital urinary tract, the CNS, and then the thyroid gland. So non-Hodgkin's lymphomas can go up to these areas and bring about cause about or bring about cohesive masses. And of course, depending on where it has gone, if it is within the GI, rather if it is within the GI, then you'll have issues like maybe stomach ache, fullness, and you know that the experience as if you're full, you know, something like that. If it is within the CNS, you might have issues that have to do with intracranial pressure, increase in ICP. You can have issues like, you know, confusion, coma to the extent, you know. So depending on where the mass has gone, then you can have effects there. Yeah, if it is within the bone marrow, then you see a separation of the bone marrow and other, you know, and even the cells themselves, because the bone marrow is not, you know, is not optimally, you know, functioning. So depending on where these tumors have gone or other areas of involvement, then the patient can present accordingly. So what do we, as far as evaluation and treatment is concerned, usually it is, we shall not go so much into the staging of non-Hodgkin's lymphomas. We shall not go so much into that, but it is very important to know the stage. Right? It is very important for you to know the stage in which you are dealing with as far as non-Hodgkin's lymphomas are concerned. And therefore, the stage basically determines the kind of treatment and the prognosis you have for such a patient. Yeah? Biopsy, CT scans, of course, a biopsy will help to tell us the kind of lymphoma it is, whether Ritzenberg, whether Hodgkin's or non-Hodgkin's, and then a CT scan will help us to show us, you know, other structures that have been involved. Yeah. So if it's within the GI, then the CT scan will pick it up. If it is within the CNS, then the CT scan will help, you know, pick it up. Yeah. So CT scans of the neck, the chest, abdomen, pelvis, as well as bone marrow aspirates. These are basically used, or these are done for us to pick up or to see the extent of spread of or involvement of this, you know, of this tumor. So success of treatment is basically dependent on the type of lymphoma, the stage of the disease, the type of the cells involved, involvement of the organs, you know, outside the lymph node, the age of the person, and the severity of the body's reaction to the disease. So basically, how you respond or the success of the treatment will depend on those conditions. The success of the treatment will depend on the conditions. And low-dose chemotherapy has been followed by stem cell transplant in non-Hodgkin's lymphoma, just like we saw in leukemias. Yeah, stem cell transplant is what can help successfully handle these conditions. And remember, we said if you are to get a transplant, then you have to first have chemotherapy to make sure that you are in the period of remission, and then sometimes also radiation as well. Yeah, before they do, before they do stem cell transplant. And remember, we said it can be either allogeneic or autologous. Yeah, and depending on the different donors, as we saw in leukemia, then if you have compatibility, then you can go ahead and and have a stem cell transplant. However, we said some of these are very, very expensive and not done in Uganda, but in developed countries they can be done. Yeah? Radioimmune therapy with radioimmune therapy, which basically combines radiation with monoclonal antibodies is also available as a mode of treatment for these conditions. Yeah? Antibody therapy, of course, we don't have these at the moment in our country here, but antibody therapy, basically these help with, there are also modalities of treatment. Yeah? There are also modalities of treatment. They basically help to destroy, the cancerous cells. And so it is very important that they are used. However, generally in Uganda here, our patients usually undergo chemotherapy and radiation, especially for these kind of lymphoma. All right. So the other kind of lymphoma that I want to talk about is Bucket's lymphoma. Yeah, Bucket's lymphoma. Yeah. Bucket's lymphoma, and this lymphoma is named after Professor Bucket. Yeah, it is named after Professor Bucket, who did a lot of work. Yeah, as far as this kind of lymphoma is concerned, and he found out that basically it is most prevalent. It is most prevalent in East Africa and Central Africa. Yeah, Professor Bucket found out that it's most prevalent in East Africa, Central Africa, and New Guinea. And it is basically characterized by rapidly growing tumor, yeah, of the jaw and the facial bones, as we are going to see the diagram. Yeah, so it is rapidly growing. It is rapidly growing tumor of the jaw and facial bones. So the jaw and facial bones, that tumor basically affects the jaw, and facial bones. And of course, it can also involve the abdomen, yeah, and is basically characterized by extensive bone marrow invasion and replacement, yeah. And Epstein-Barr virus. Professor Bucket found out that Epstein-Barr virus, Epstein-Barr virus was implicated. Was one of this is basically a virus, yeah. So I found out that this virus, which loves or which likes especially the nasopharyngeal secretions, yeah, is associated with this kind of lymphoma especially in African children, yeah, in African children. So whenever you see someone with something like that, yeah, a child like that, that is most likely what we refer to as Bucket lymphoma, as you can see. Yeah? So that swelling of of the jaw and facial bones, yeah, that is Bucket's lymphoma. And Epstein-Barr virus is one of the organisms that is implicated. Yeah? So it is suspected that suppression of the immune system, as far as the pathophysiology is concerned, by other illnesses increases the individual's susceptibility to Epstein-Barr. In other words, this virus would not be so much of a problem. But in addition, if you have a reduction or a suppression in the immune system, yeah, if you have a suppression in the immune system, then this one, it kind of like the patient becomes more susceptible. Yeah, it becomes more susceptible to this Epstein-Barr virus. Yeah, And B cells are particularly, sensitive because of the specific surface receptors for, for Epstein-Barr. So basically, these go and attack, they go and attack the B cells. And if you remember very well, we say the B cells, they come from the lymphoid lineage. Yeah, they come from the lymphoid lineage. So the B cell undergoes, chromosomal translocation that results in, overexpression of the oncogene. In other words, there is when this virus attacks the lineage of the B cell, yeah, it basically kind of like causes transformation of of the chromosome, and once it does that, then basically the B cell now the B cells that are being manufactured, yeah, the B cells that are being manufactured, they become abnormal, yeah, they become abnormal. So the B cell undergoes chromosomal translocation that results in what we call overexpression. Yeah? So if it undergoes an abnormal change, then we have overexpression of an abnormal gene, yeah, of an abnormal gene, which basically causes loss of growth control, and so the B cells start, accumulating, leading or bringing about, that structure there. And of course, the most common site of there might be many sites of chromosomal translocation, but they are saying that the most common sites of translocation happen, in chromosomes 18, rather in chromosomes 8 and in chromosomes 8 and 14. Yeah. But the point to take home here is that Epstein-Barr is implicated, yeah, and it basically affects the growth or the multiplication of the P lymphocytes, leading or bringing about that. Yeah. So as far as clinical manifestations are concerned, in non-African buckets is most in the non-African. Remember, this bucket lymphoma is also found even in outside their countries. Yeah. So when you say non-African, it basically means it's maybe Europe, or United States. Yeah. So in non-African bucket lymphoma, the most common presentation is basically abdominal swelling. Yeah. So as we saw earlier on, we said that it is not only that, but it is also associated with abdominal swelling, as we saw earlier on in the presentation. So more advanced disease may involve other organs like the eyes, the ovaries, the kidneys, the glandular tissues, tonsils, and presents with with type B symptoms, like for example, night sweat, fevers, weight loss, among others. Yeah. So basically, that is the clinical manifestation of the non-African. For the African, we basically have this. Yeah? For the non-African, we basically have abdominal swelling, but also involvement of other structures. So children are usually treated very well with cyclophosphamide and with the therapy. So by the way, it responds very well to this. Yeah, it responds very well to this chemotherapy, and specifically cyclophosphamide and and radiotherapy, yeah, or radiation. Yeah. So, however, the American type is quite resistant to treatment. Unfortunately, we don't have this, but adjuvant monoclonal antibody therapy with rituximab appears to be a promising agent for improving outcomes with maximum toxic effect. Now, we don't have that, but In Uganda here, what we usually use is radiation and chemotherapy, specifically cyclophosphamide. All right, so basically that has been that about lymphomas. Yeah, we talked about Hodgkin's lymphoma, we talked about non-Hodgkin's lymphoma, and Burkitt's lymphoma. Yeah. So also within your course outline is another tumor. It's not a lymphoma. Yeah, it's not a lymphoma. It's another tumor. And that tumor is called Wilms tumor. Yeah, Wilms tumor. It is basically a yeah, it's a nephroblastoma. Yeah, in other words, the cells of the kidneys. Yeah, it arises out of the cells of the kidneys, and it is malignant, by the way. Yeah, it is malignant. It is not benign. And so by malignant, we mean that it can spread to other areas and also bring about effects of bad tissues. All right, so let's talk about Wilms tumor. Yeah. Wilms tumor also referred to as a nephro. Also referred to as a nephroblastoma. Yeah, a nephroblastoma. Now, so Wilms tumor is also referred to as a nephroblastoma. It's basically a malignant tumor of the kidneys. Yeah. So in other words, we are saying if these are the kidneys, if these are our kidneys, if those are our kidneys, that is our kidney, then you can have the tumor, you can have the tumor develop around here. Yeah? You can have the tumor there. Yeah? You can have the tumor there. Yeah. So basically, malignant tumor and usually it typically occurs in children, and it is one of the commonest pediatric malignancies. It ranks 50. Yeah, it ranks 50. Now, it basically affects girls mostly. Yeah. So one in 10,000 affecting girls mostly, and most of them are diagnosed by the age of before the age of 5. To be more specific, usually most of them are diagnosed at the age of 3, yeah, 3.5 years. Yeah. So usually it does not go beyond 5. Yeah, before they are picked up. Yeah. So, and most commonly, it is unilateral. In other words, it's one kidney which is affected. Yeah, but there are a few cases of bilateral involvement. Yeah, and majority of 75% occurs in otherwise normal children. Yeah, and however, about 25% other children have developmental abnormalities. But we are saying that majority of these occur in otherwise normal children. Yeah, and less than 30% basically occurs in those who have developmental abnormalities. The good thing, it is highly responsive to treatment, and also with about 90% of patients, surviving at least 5 years or even more. Yeah, so it responds to treatment very well. All right. So what is the etiology, or what is the cause of Wilms tumor? Now, Wilms tumor, there is no known cause. Yeah, there is no known cause of Wilms tumor. However, genetic mutation. Yeah, genetic mutation is looked at, especially the abnormalities in the genes, specifically that WT1. Yeah. So WT1 is basically it's an oncogene, yeah, that is implicated in in the development of Wilms tumor, and it's usually at chromosome at chromosome 11 on the location or the site, chromosome number 11 at the 13, at the site 13, as you can see there. Yeah. So, so what you should know is that the etiology, usually the cause is not known, but mutation and abnormal genes or oncogenes can basically bring this about. Yeah. So it is believed that the tumor begins to grow in, as far as fetus, development. And so it begins to grow, in the fetus, yeah, as the fetus develops in the womb, with some cells that are destined to form into the kidneys, malfunctioning and forming a tumor. So we say that this tumor is basically, it arises out of the cells of the kidneys. Yeah? So, and it happens intrauterine, within the womb, yeah, within the fetus. And so these cells that were naturally supposed to form the kidneys, yeah, they basically malfunction, or we get the out of them comes that oncogene, yeah, which basically ends up forming, the tumor. Yeah. So basically, that is that about the etiology. Now, how does it manifest? Wilms tumor is basically diagnosed at 3.5 years, and the common feature is basically an upper quadrant mass, yeah, yeah, which is firm and non-tender. So you have an upper quadrant mass, yeah, upper quadrant, and then it is firm and non-tender, yeah. So the fact that it is firm and non-tender, that does not warrant that the healthcare worker should keep on palpating it. No, actually, one of the precautions that should be taken is that once it has been realized that this is Wilms tumor, then there is no need for over palpating it, because in that way you can cause dislodging of some of the cells, and they end up metastasizing to other structures. Yeah. So sometimes you have abdominal pain, which occurs in about 30 to 40% of cases, of course, related to rapid growth of the tumor. You can have, since it's located within the kidney, so you can, if it grows very big, then you can have, compression of urethral structures, leading to, obstruction. Yeah. Issues like constipation, vomiting, abdominal, distress, anorexia, weight loss, dyspnea. If it goes so large, yeah, it might even compress, it might compress or compromise the space within the lungs have to, to do their functions. Yeah. So if it grows well, it might compromise with the respiratory system, and therefore we realize, we have dyspnea. All right. So other manifestations, Wilms tumor may also be associated with what we call hypertrophy, where we have one side of, one side larger than the other, as you can see in the diagram. So because of the tumor, it can bring about hypertrophy, where you have one side of the child larger than the other. You can also have aniridia, which is basically complete loss of the iris. You kind of like the eyes of this child are like those of a doll. Yeah, they become like those of a doll because of the iris is kind of like completely lost. Other signs and symptoms may include hypertension. Remember, this thing is on the kidneys, and the kidneys play a very big role as far as control of blood pressure is concerned. You remember the renin angiotensin aldosterone system, yeah. So they can compromise that, and as a result, lead to issues like hypertension, yeah. So fevers, caused by tumor necrosis, and then you can also have hematuria and anemia because this tumor is rapidly dividing, yeah. It basically destroys adjacent tissues, and they can be bleeding around the area. So ending up bringing hematuria and anemia in the long run. All right. So as far as metastases are concerned, the neoplasm can metastasize either by direct extension or by bloodstream. And of course, they may invade what we call the perirenal tissues, because that is where it is adjacent. That is where it is. So those are the places adjacent to it where it can easily metastasize. Yeah. So perirenal tissues, lymph nodes, the liver, the diaphragm, abdominal masses, and the lung. Yeah. So it is very important that you're cautious about these places where this tumor, or where metastasis from this tumor can go. Yeah. Now, as caution, especially to the nurses, it is very important, to prevent palpation, over palpation. So you need to usually we place a mark that on the bed of a patient, do not palpate, yeah, because we don't want to risk metastasis, yeah. So we restrict if we have noted or if we have confirmed that this is Wilms tumor, then we restrict palpation as much as possible. So what do we do as far as diagnostic evaluation for this condition is concerned? We have things like you do laboratory investigations where you do CBC. Now, of course, CBC is required because remember we talked about anemia. We talked about issues. Yeah, we talked about issues of anemia. And so you want to know the baseline, yeah, and also you want to know the HB and all those things, yeah. Then the platelet count, urinalysis for hematuria, liver function tests. Remember, we said some of these can go up to the liver. They can metastasize up to the liver. So you want to do liver function tests. You want to do renal function tests. You want to do blood chemistry. You want to do serum electrolytes. You want to do uric acid. You want to do urea creatinine and all those things. So all these are lab investigations that we want or will help you in the process, yeah, of basically management. Yeah. And then as the different imaging studies that are done, ultrasound sonography. Now, usually this is initially done for initial diagnosis of renal or abdominal mass. Yeah. So we have to do that. Then possible renal vein or inferior vena cava, thrombosis, because of remember we talked about because of the metastasis, but also Yeah, so you want to see whether there's any possible renal, if you have vena cava or renal vein, thrombosis. And also CT scan of the chest and abdomen, and to know whether there are metastases there. Yeah, to know whether there are any metastases there. So basically, those are the diagnostic evaluations that are usually done. Yeah? And as far as management is concerned, now with management, maybe one other thing I did not talk about is that Wilms tumor is also staged. Yeah, but of course we shall not go into those details because we are not oncologists. But so management will depend on the stage. Management will depend on the stage of this tumor. Yeah, and as a result, so it can be surgical. It can be just like any cancer. It can be surgical. The modalities are surgical, where you can have partial or complete nephrectomy, where you remove, yeah, you can remove the entire kidney, or you can basically just excise the tumor. Yeah, so there you can have partial or complete nephrectomy. Then radiation therapy and chemotherapy. These are the modalities of treatment that are usually given or are usually done for these patients who have Wilms tumor. Now, as far as nursing management is concerned, you need to monitor vital signs, especially blood pressure. I hope you know the importance of that. I cannot expound more on that. Then you need to avoid palpation of the abdomen, or rather of the abdomen. So you need to put a sign, do not palpate. Yeah. So you also need to measure abdominal guts, yeah, at least once daily, because remember we said it expands highly. So you need to measure abdominal gut. Why is that important? Because if it increases, then it increases the risk of invasion into the liver. It increases the risk of compromising with the respiration and the lungs, the lungs expansion. So that is why it is very important for you to be able to carry out, abdominal gut measurement. Yeah, and then also as far as the post-operative interventions are concerned, you need to monitor temperature and blood pressure closely, signs of hemorrhage and infection, intake and output. You need to monitor that. Monitor abdominal distension and also bowel sounds and other signs of GIT activity because of the risk of obstruction. So basically, that is it about Wilms tumor. And so in this lecture today, we started with the lymphomas, and we talked about Hodgkin's, we talked about non-Hodgkin's, then we talked about bucket lymphoma, and then of course plus the management, and then lastly we talked about Wilms tumor, which we said is not a lymphoma, but it is a nephroblastoma. That marks the end of this presentation. Of course, we shall have live lectures, so please do not get worried that all the time you will be seeing recorded videos. No, we shall have time for live lectures when that time comes. Yeah. So otherwise, thank you so much for watching this video up to the end. And yeah, so this marks the end of the cellular. Was it cellular carcinogenesis? Yeah. So this marks the end of cellular carcinogenesis. When we meet again, or when I record a video, then that will be another topic. Thank you so much.